Good morning, moderators on the dais, and my very special thanks to Dr. Kumar for including me in his prestigious course. I'm not showing the major complications like was shown by the earlier speakers, but I'm just generally going to be telling you how the complexities in LRCS become a child's play because of the high-end technology which is there. So, it's as if the surgery is gone to a beginner slope only, even in the most difficult situations what was the idea behind showing that video. So you can see this is a fairly hard cataract, and the ease with which you're able to get the rexes out. And what you can do in a hard cataract, you could just increase the grid pattern so that there are smaller multiple grids. And if you look carefully, the intraocular pressure is sitting at 40, and all that is being done is just burying the phaco probe in the nuclear matter and just pricing apart already the created fracture planes by the femto laser. And then you would say it is a practically unedited video, and the CD is hardly 9 to 10, and with absolute ease you're able to remove the nuclear fragment. Of course, removing the cortex is a bit of a challenge in the early days because the cortical fibers are vertically cut. But then, as you can clearly see, now I've gone on to capsule polishing and then placing the intraocular lens. And the surgery tends to become most premium, and even in these challenging cases, and you can see multifocal lens has been placed. Now this is a small pupil. What you could do in a femtocataract, you could downsize the rexes into going into a pupil maximized thing. So you've used a 4.3 rexes here, and I've created the fracture planes and the grid patterns. Ideally, for this small pupil, I would have used an iris retractor to make the surgery absolutely easy and uncomplicated. But because these fracture planes were there, and maybe at the most I would have brought a nuclear fragment into a supracapsular plane. But otherwise, although the pupil kept going down, you can see the ease with which I could do the surgery. Removal of the cortex would be a challenge, as in any other small pupil, you need to go in the exact plane. But otherwise, the surgery was completely uneventful, to the extent I could even go remove the viscoelastic from behind the lens. The advantage of using a femtocataract platform for a total cataract is you get a well-defined rexes. Sometimes the tissue bridges may not be cut, which is quite rare. You could try even increasing the energy to get your nuclear fragmentation. But more importantly, you are able to totally do away with the Argentinian flag sign, or sometimes the rexes extending right and creating a wraparound, and a posterior capsular rent would have occurred. And then you're able to finish your rexes and go on to creating the main port and the side port incisions. The important thing when you are going to the actual surgery, you're releasing the vacuum, of course, and when you take the patient up, normally I wouldn't stay in the capsule because it would be a free-floating rexes in most situations. But in this particular case, you wanted to know whether you have a free flow. The rexes was free, and you could see it is a floating rexes. But although the energy levels to increase, the fragmentation had not occurred, and I could still continue and complete the case. This was a high myope, and in a very high myope, the challenge is that the anterior chamber could suddenly become deep. There could be a reverse pupillary block. So with the femtocataract platform, all I've done is just brought down the intraocular pressure down to 30 on the Centurion. So it actually appears as if I'm doing a very routine soft cataract on a very stable platform with a stable anterior chamber. And in no time, with just a CDE of 0.76, the fragmentation and the emulsification is completed. And of course, the cortical leaves are just removed, and a good polish is done, and the lens is placed. And again, a moderately challenging cases becomes a very routine scenario, and a premium lens makes it a premium surgery. Now this was a very shallow eye, and a PI is there. You can see a high probe. Again, all the precaution that I've taken was just ensuring that my hydros are gentle and my parameters are a little lowered. And but again, you can see that the nuclear fragments just come gobbling up. There is hardly any editing done in these cases, and you can see that the ease with which the surgery is being done. Of course, the cortex removal in a small pupil is a minor challenge. You need to ensure that you retract the iris and go on the right plane and position the lens into the eye, and of course remove your viscoelastic, and then this also becomes an uneventful case. Taking you further, this was a case of a capsule fibrosis. So the only thing was done was the rhexis was so sized that it was beyond the area of the riders which were coming from the fibrosed capsule. It was not an entirely fibrosed capsule, and you can see that the rhexis was done everywhere excepting in that particular one segment where it was still attached, where the tissue bridges had not got perforated. And so all you need to do is to just go in with your second instrument and just gently tease it, and you can see you have a nice round rhexis, and the surgery goes on uneventfully. Taking you on to the next situation. This was a extremely subluxated cataract just held by few zonular fibers, and dealing with this cataract had you opened the eye would have been quite challenging because the few existing zonules could have given way with the anterior chamber shallowing and deepening. So now I have just decentered the rhexis and made it smaller so that it comes to overlie the lens material. And then not only that, the nuclear fragmentation and the softening, all these things continue in the routine fashion. Now, because of the pseudo-elasticity of the subluxated cataract, creating this kind of exact size rhexis would have been quite a challenge in a normal course of event. But being on a femtocataract platform, this is something which gets totally obviated, and you have a consistent round rhexis. And this further softening of the cataract makes it even more easier. Just a gentle hydro is done, and the soft nucleus is nudged into the supracapsular plane, and very gently you are able to tease the cortical fibers and remove it, and you can see that the area of dialysis just continues to remain the same, and I am able to place a CTR and position it such that the CTR comes to overlie the area of maximum dialysis. Traumatic cataracts are non-progressive zonulopathies, so you can just position your IOL, which would go into further stretch, and this might be a solution in most cases. Now this is a polar cataract, so the plan of action was to create multiple cylinders and chops. Now having multiple cylinders one below the other is acting as a protective cushion for the deeper posterior capsule, which is going to dehisce at any point of time. And then the chops and the rhexis, you can see it's a free floating rhexis. So just a gentle hydro delamination is done and the bag is decompressed. So now I'm able to operate on each superficial plane, just eating up the little bit of the nucleus which is protruding, while all along the deeper cylinders remain intact, so that these intraocular maneuvers are not impinging on the posterior capsule at any point of time, and it is not being affected by the hydrostatic pressure changes which is occurring in the eye. And then it comes to just that last epinucleus which just gets folded up because it's already eaten up and there is hardly any strength left in this nuclear matter. And then gently teasing the cortex, because at any point of time the posterior capsule can dehisce in a posterior polar cataract. We need to be careful, but then the major challenge is done and the IOL is placed, and it's all about removing the viscoelastic and getting yourself out of the case. Now this is a case of 4 or 5, 8 RK incisions. So the challenge is these are hypertrophic scars, so there could be a possibility that the rhexis may not be intact. There could be a runaway rhexis at any point of time. So maybe you could just step up the energy, but because of the grid pattern, I could not even visualize whether the rhexis was actually intact. So just went about emulsifying the cataract, and then the cortical removal also happened. But if as I am removing the cortex, if you look carefully, sub-incisionally there's a little runaway of the rhexis just in the area of that RK incision, but the surgery seemed to have gone quite comfortably. So now all I have to do is just position the IOL optimally so that there's adequate rhexis overlap in all areas excepting where that rhexis has run away, and just a somal hydration. Now this is the intacs is there and the patient has a cataract. Now the overlying intacs could prevent the femto disruption of the anterior capsule. So there could be tissue bridges which have not been perforated. So I needed a cystitome to ensure that the rhexis was actually cut. This intacs does hinder the visualization, especially when you are going about to doing your CHOM or removing your cortex, because the rhexis tends to retract behind the intacs. But thankfully, because of the fragmentation which was done, the surgery again becomes quite a child's play. This was a case with the ICL with the cataract. So I've generally played with the offsets so that the offsets are made deeper to reach out to the capsule underneath the ICL. And again, the posterior capsular offset has also been raised because there's going to be a lot of cavitation bubbles. There could be a capsule blowout. And we all know the biocompatibility of the ICL is such that you can easily take it hand over hand technique. Notice that cut on the ICL, which indicates that the femto disruption has created a cut, and you are not too sure whether the rexus has actually got cut. So you need to use a cystotome to ensure it's got cut. But beyond that, you could just use a flip mode, because these anterior subcapsular cataracts are very soft cataracts. So the idea of showing these multiple cases was that by being on the femtocataract platform, you're able to deal with any of these situations and get done as if these were moderately easy soft cataracts. Thank you.